This is the Healthcare Education Transformation Podcast, a podcast brought to you by two physical therapists devoted to helping physical therapists and other healthcare providers become better educators to patients, students, the community, and each other by interviewing prominent and passionate people within the realms of healthcare and education. The Healthcare Education Transformation Podcast is intended literally for educational and entertainment purposes only. No clinical decision-making should be based on only one source, and therefore this podcast should not be used as personal medical advice. While care has been taken to ensure accuracy, occasionally mistakes and factual errors can be present, as we are only human. This is our journey on the road to becoming better educators, so get ready with your pen and paper as class is about to begin.
Hello, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm your host, F. Scott Field, and as always, I'm joined by my co-host, Brandon Pone. Today, we welcome Dr. William Jeffries, who is the Senior Associate Dean for Medical Education at the University of Vermont Larner College of Medicine. We'd like to give a shout-out and a personal thanks to Dr. Gail Jensen at Creighton University for telling us about the active learning method that the University of Vermont has adopted, discontinuing their traditional lecture-based methods. Dr. Jeffries, thank you so much for coming on the show today to speak with us, as we greatly appreciate your time and efforts. Do you think you could give our listeners some background about who you are and about your experience in the field of academia?
Sure, and thanks for having me on tonight. My background is as a basic scientist. I've been a scientist for over 30 years. And I have a particular interest in medical education, although I was once in charge of a graduate education program as well, getting people their PhDs in pharmacology. I've been at several medical schools. I was at Creighton University for 21 years, and in 2009, I came to the University of Vermont as the Senior Associate Dean for Medical Education. And at Vermont, I'm primarily responsible for the curriculum, the admissions for medical students, student affairs, and all the educational facilities.
Awesome, Bill. And, when I first heard about this method, I was kind of like, I wonder how that whole process started with the no lecture approach. And do you think you could tell our listeners kind of the story about how the process to change to the active learning paradigm started at the University of Vermont? And could you discuss some of the key research in detail that kind of drove that decision to do that?
Sure. As an educator in a medical school, I had spent a lot of time teaching and was quite enamored with teaching, and to the point where I was put in charge of the medical education curriculum at Creighton University. And during that time, I spent a great deal of my efforts developing lectures and delivering lectures. And one of the things that happened along the way was that because of my experience in medical education, I was invited to edit a book on the teaching methods for teaching medical students in medical school. And with my co-editor, Dr. Katie Huggett, we proceeded to gather all the best practices and all of the different methods for teaching medical students and put them into one book. And when we were doing that, it became apparent there that I knew very little about medical education compared to what I thought I knew, but B, that although my area of interest and expertise was large group teaching, it became apparent that there was a number of methods, particularly used for large group teaching, that were starting to emerge that looked like they increased student learning and student satisfaction. And among those were the large group methods that had been becoming prevalent in physics teaching, particularly fostered by Dr. Eric Mazur at Harvard, and also in business school, Dr. Larry Michelson, who teaches a method called team-based learning. And those two methods seem to be quite effective and interesting to me. So when I moved to Vermont, I warned them what was going to happen. I said, I want to start introducing these types of methods more and more into the curriculum. And by 2012, we were really on a path to do that, to increase the amount of active learning. By about 2014, a meta-analysis came out in the Proceedings of the National Academy of Sciences looking at these active learning methods versus lectures, and gathered 225 different studies of active learning methods in science, technology, education, and mathematics teaching, and compared their efficacy. And the data that came out were pretty staggering. Of these 225 studies, none found that lecturing was better than active learning. And in fact, it was quite the opposite. The student performance increased by about half a standard deviation when you're looking at the grades of the course. Exam scores improved by about 6%. In these courses, and students in classes that eliminated lecturing, students that had lecturing versus the active learning were about 1.5 times more likely to fail a course. So it was pretty clear that lecturing among all the large group methods of teaching was really the least effective. And so we made a decision to eliminate lectures in our curriculum entirely.
Yeah, Bill, those are some pretty staggering numbers. I mean, do you know of any of the limitations of some of these research articles you just mentioned? And are you aware of any maybe research that refutes active learning models?
There's been a number of attempts to refute them, but the most of the data that are presented are anecdotal and really don't pass muster with respect to statistical rigor. The only possible way that you could argue against it would be that there would be a publication bias. And that is, if you find no difference between active learning and lecturing, that you wouldn't be inclined to publish it, or that even if you were trying to introduce a new learning method and it came out worse than lecturing, again, you wouldn't be inclined to publish that. But the authors of this meta-analysis, Freeman et al., who looked at these studies, did an analysis and determined that you would have to have over 400 studies that were failed to be published that would, in order to overcome the results that they had found. One other thing I would say about the Freeman study, and this was really compelling to us as a medical school, was that they analyzed this as if it were a prospective randomized drug trial. And they said that basically if this were a prospective randomized trial, that they would have to stop the study for ethical reasons because the lecturing was significantly worse than the active learning methods.
Wow, that's pretty interesting to hear, and that's really how powerful that is. And Bill, after reading kind of the story a little bit more about what happened, it seemed like when you first implemented this idea, it looks like you definitely had some initial pushback. But after you showed the evidence of how more beneficial it is to professors, it seemed that they came around and it seemed to be okay. But I'm going to kind of pose a hypothetical situation to you. So what if the roles were switched? So how would you recommend that a professor within a medical school go about bringing up this idea, or perhaps any other innovative idea that is perhaps unpopular to improve teaching, to the dean for consideration for implementation?
Well, I think that the ways that I used it to convince the faculty are the same way that you would use it in reverse. The people that work at an academic medical center are basically all scientists and clinicians. And if you create an emotional argument around something, you're not going to get very far. But if you provide data to show that your method or your idea has merit, it's pretty hard to ignore that. And so if you show that this method that you're trying to introduce has proven efficacy and actually is superior to something that is in current practice, most people find that a pretty compelling argument. It's certainly something that I found compelling when I was in a position to make a decision about it. And so I think that is one of the keys. The other one is that most faculty have a small component of different courses. And certainly in medical school, we have a lot of team teaching, and faculty are pretty much left to their own devices with respect to introducing new methods or new materials. And so we have had this for many years in the various curricula that I've been associated with, and that is that you can just introduce it yourself and to see if it's any good or not, and to test. And everybody knows the scientific method at a medical school, so you can design a small study, introduce a new method, and study it, and then bring it back to people who are in charge of the courses or in other circumstances, and really provide the data and show that it works. And finally, if you convince the students that they're benefiting, and the students know that they're benefiting by their virtue of their grades or their satisfaction, they'll want that, and they'll want to know why these types of methods aren't being introduced in other aspects of the curriculum.
Yeah, Bill, I think student buy-in is a huge token for sure. And as you know, Brandon and I are both physical therapists, and we love learning from other healthcare professionals. And we're hoping to enlighten our audience about some of the many healthcare fields out there. So could you break down for us how the medical program is structured at the University of Vermont, going through the 3 levels, and how the active learning component is implemented?
Yes, the curriculum is divided into roughly 3 equal-ish parts. The first is called the Foundations of Medicine, and that covers all of the basic science aspects of things that you need to know for medicine. And those courses are very ripe for active learning intervention because the students are primarily working in classrooms and studying from videos, books, and et cetera. And the students first take a course called Foundation of Clinical Sciences, and that is a fundamental coverage of the basic sciences that are foundational to medicine. And that sort of is a leveler as well, because people who come to medical school generally come from a variety of different backgrounds and majors as undergraduates. So we want to make sure everyone's on the same page. Once they're finished with that, they go through an organ-based system approach, and we have 6 or 7 courses that they go through up until January of their second year. At that time, they take their United States medical licensure exam, step 1, and passing that, then they move on to clerkships. And clerkship is a year-long experience in which the students go through various core experiences that are fundamental to the practice of medicine. They do it in the hospital or in an ambulatory setting, and do the standard clinical care and learn in that model. And usually they do it in the presence of residents and attending physicians who understand what the curriculum is. And there's a lot of teaching at the bedside. But there's also a lot of didactic teaching in that as well. And the students ripe again for active learning by removing those lectures and inserting active learning that are very pertinent to their cases. Finally, we have the advanced integration period, and that starts about toward the 2/3 of the way through the 3rd year. And advanced integration comprises the elective portion of medical education, where students can try out different specialties and do 1 month or 2 week rotations in various things that they are interested in. There's also some requirements as well. They must do an acting internship in medicine. They must do a month of surgery. They must do a month of emergency medicine. And going through all of that at the same time, they are taking this step 2 of their licensure exam. And they're also applying for residency placement. Following graduation, all of the graduates move on to residency training, which is between 3 and 5 years of additional clinical experience in a specialty.
Yeah, no, that was a good take. And Bill, something I didn't tell you early before, but my fiance is actually just starting her residency now for general surgery. And so she's got a 5-year one. So
yeah.
After hearing kind of,
And then fellowship probably after that.
Probably. But the thing is, she's not sure exactly what specialty she wants to go within that yet. So she's just going general to figure it out. But yeah, after hearing kind of what you've gone through, I'm like, yep, this sounds pretty familiar.
Right. And physicians are notoriously addicted to training. So they invent additional fellowships and other experiences, and plus all of the continuing medical education that's needed to maintain licensure, and then recertification every 5 years in its specialty. So there's a lifelong training that has to happen because you're continually certifying that you're fit to practice. And that means that we really want to teach students to be lifelong learners and to engage in active learning as they go through their careers, because that's the way that you get the best retention and the deepest level of understanding. And to have that is a big advantage as you're going through these every 5-year recertification exams.
Yeah, for sure. And kind of what you said before, Bill, about how the data really has been pretty staggering overall. And of course, after kind of looking at the website, I see that you guys have an evaluation and research group in the works already for the program at University of Vermont to kind of assess and see how the active learning model is in terms of whether they're being effective or not. But Do you think you could go into a little bit more detail about how this group specifically operates and how you guys are measuring effectiveness?
The faculty, as one of the conditions of implementing active learning, want to study it. And as I said, everyone's either a scientist or a clinician, but all of us follow the same rules of evidence and ensuring that we're actually doing something meaningful. And in addition, we want to gather those data to do quality improvement over time. And so it's important when you're introducing something like this to have an evaluation plan. And so we formed a group through our teaching academy. And I should back up and point out that in order to get the faculty well-versed in active learning methods and to help their careers as educational researchers, we formed a teaching academy. And this is a group of faculty who have gone through a vetting process and are committed to creating a community of medical education scholars, and they help each other and help the remainder of the faculty develop their teaching skills. And it's led by an endowed professor of medical education who has spent her life really as a medical education researcher and a faculty development expert. And so we feel pretty well equipped then moving forward that we have the people that we need to develop this. One of the groups that the Teaching Academy has formed is the evaluation group, and they are busy designing tools to help study the implementation and success of active learning. One of the rules that we invoked was that all of innovations that are in the curriculum should be studied and made into scholarship. In addition to just doing it, we want to study it and disseminate it to other schools and help them develop a more rigorous curriculum for medicine. So we also want to develop products and modules for teaching various things in the curriculum. And one of our imperatives there is to make sure that those products get out there. They're put into national curriculum repositories and are available to other medical and health science educators to use in their curriculum as well. So those are our criteria. We're getting a lot of feedback.
Yeah, Bill, I mean, this sounds like a really innovative program that I could definitely see catching on like wildfire across the nation. That being said, aside from the degree of active learning utilization being done at the University of Vermont, how is this program similar and how is it different to many of the medical school programs in the U.S. currently?
Well, I would say we're on the leading edge of the active learning implementation. There's other schools that have been really embracing active learning as well. And so I don't want to pretend that we are the only one, but we're certainly among the leaders, I would say, in this regard. And one of the other schools is Stanford, one is Harvard, and another one is Commonwealth Medical School in Scranton, Pennsylvania, and another one is Wright State in Ohio. These are the schools that I think are really taking the leap, but we're one of the very first to say, lectures are out, and we want to phase those out of the curriculum. So that kind of makes us unique. Another thing that makes us unique is the structure of the curriculum that I explained earlier. The 3-level curriculum in which the foundations is only about a year and a half is actually unusual among medical schools. It's becoming a trend to get to that point, but we're one of the very first of schools, if not the first, to dramatically shorten the basic science years. And this creates room at the other end of the curriculum so that students have more time in the 4th year to explore their career options and to help them with their residency placement. So those are some of the unique aspects. But that being said, all medical students in this country have to go through the licensure process. All of them have a basic science component and a clinical education component, and all of them have to meet standards of accreditation, which are pretty rigorous and ensure that although medical schools can be different from each other, the end product is pretty much assured to be similar.
Yeah, Bill, and the similar thing kind of works within the field of physical therapy as well, in regards that, the academic, there's a didactic and there's a clinical education component. Of course, the schools kind of base the curriculum and stuff based on, off of accreditation board, and also what's kind of on the national licensing exam. So there's definitely some similarities in that regard as well. And, I realize this is the next question I'm going to ask you is kind of a loaded one here, but Bill, in your experience, what are some things that you feel need to change in medical school education to better prepare students for being physicians in today's day and age?
Well, I think we need a whole other podcast to get through that, but I think that there's a few things that are important, and I think that various medical schools have embraced various aspects of this, but I don't think anybody has all of the intangibles down perfectly, including University of Vermont. But I think that we need to focus on a closer alignment between what medical practice actually is and what's taught in medical school. And healthcare is changing so dramatically that it's sometimes difficult to keep up with those trends and to really match the graduates with what's needed in the workforce. But having that in mind, I mean, we should be focusing on those things, because we want to our fiduciary responsibility as a medical school is not to students, it's to the public, and we make doctors for patients, and therefore we should probably try to align that practice with what we teach as much as possible. So we really should focus more on practice-based education. The fact is that a very large portion of medical education was inpatient, but we know that medical care is largely outpatient. So there's a difference right there that we have to focus on. And I think that a lot of the reason why we focus on inpatient so much is that faculty and just the physicians that are practicing like what they do, and they want to make sure that they can attract medical students into their own fields. And so, and all of we base medical schools at hospitals, and therefore we have to teach way too much inpatient medicine. The other thing is we have a time-based curriculum in most medical schools, and really that doesn't mean anything. We really should focus on competency-based education and ensure that everybody is at the same level of competency when they graduate. And that means it's, for some people, medical school could be shorter than 4 years, and for some people it should be longer than 4 years. But that's something that we haven't approached just yet. But in alignment with practice-based education, we obviously have to have a much greater attention to interprofessional education. Medicine is not practiced in a silo, although it may be taught in a silo. And so we have to get the other professions much more involved and learning from each other and helping that the education move along. Finally, as I said, it's a team-based sport, but we very often teach medical school in a single student environment. So you sit in a chair and you listen to lectures, etc. And so what we're trying to do here, and what all medical schools should be doing, is to move students more into a team-based approach where they learn to help each other, they learn to work in a team and develop non-cognitive skills that will be useful later in the practice of medicine.
Yeah, Bill, that is music to our ears, man. Practice-based learning and interdisciplinary practice are two reasons we've kind of started this podcast. So love to hear that. But what do you think medical students, practicing physicians, and medical educators can do to contribute to these issues and really help make them better?
Well, I think the practicing physicians need to speak out about it. I think a lot of the practicing docs that I talk to view medical school as kind of a rite of passage and or have a pet idea about how medical school should be changed. But I do think that saying that, first of all, medical education is important, and that we should align our practice environments with an educational environment as well, and so recognizing that we have to bring the next generation of physicians in. So we shouldn't be stuck with things like teaching services and non-teaching services, et cetera. Everything should be a teaching service, and we should really fairly compensate faculty for their time, but at the same time recognize the responsibility of the profession to continue the educational practice. But the main thing is that students and faculty should advocate for change. And really a lot of these issues are talked about, and some of them the resolutions are drawn up, but nothing ever happens. And I do think that at some point that we have to put our foot down, and the people that are involved in the practice of medicine need to be familiar with the literature, apply the rules of evidence to education, just like they do and insist on for rules of practice and scientific standards of proof. And we don't flinch looking at the efficacy of treatments when we have evidence, but when we see education, we just sort of are very nebulous. So I think holding education to the same evidentiary standards as the scientific practice of medicine would go a long way in ensuring that some of these things always happen.
Bill, no, that's a good point there. And I'm going to ask you one question that I didn't write on the script just because I kind of thought about this as you were saying this, but, kind of going through and kind of that, lack of action, why do you think that is? Do you feel like that's just more so just unsure and afraid, or you feel like there's financial reasons or incentives for that? Or I'm just kind of curious, with you being more in an inside role there, I'm just curious, what are your thoughts on that?
Well, I think that this is again another podcast, but the commoditization of medicine in general has led to a monetization of education, and so, for example, we know that there's RVUs and other measures of clinical productivity. Physicians are limited to 15 minutes per visit, and everything is down to charges and accounting for procedures, and that's how physicians get paid. When a medical student is introduced into the environment, the argument is that there's no financial way to account for that, and they slow me down, and I'm actually volunteering my time and paying money for me to be able to teach a medical student. And so we have to incorporate medical students and other health learners into the mix, the financial mix, to understand how this is going to work. And I think that having attending physicians and other faculty who understand the principles of education and are there because they want to be, will put pressure on the system and make it change. And right now we have the largest growth in healthcare right now is in the for-profit sector. These are groups that have really little or no interest in education, and at some point, we have to strike that balance and say, well, we're going to need providers in the future, and actually we need more providers than ever. And so we have to make sure that the healthcare environment always includes an accounting of the cost and structure of education.
Yeah, I think that was very interesting to hear. And, kind of in the PT realm, we've kind of faced somewhat of a similar degree in terms of kind of getting relationships and partnerships between the academic side and the clinical side. And to a degree, I mean, even so, like a lot of clinical sites take students for free, despite some of the things that the clinicians have to do extra, in terms of productivity and that as well. And they're getting to the point now in PT where some of them are actually charging the academic institutions to take a student now because of what they're going through. So I thought that was interesting to hear from the medical side of it. And, Bill, we'd like to ask this question at the end to all of our guests to see what everyone's take is. And realizing you may have brushed on this before, but maybe not. But the question is, if you could change one aspect of healthcare education, medicine or other healthcare provider related, what aspect would you change, and how would you change it?
Well, and this may be unknown to an audience of physical therapists, but or maybe not. And that is, I would change what I consider to be one of the primary drivers of medical education today, and that is residency selection. So, as I said, every medical student, in order to practice, has to do a residency, and residency program directors have devised selection practices which in large part drive the structure and put constraints on medical education and the curricula around the country. And I don't think the general public realizes this, or anybody outside of medicine realizes that this is happening. And so there's just a few things that are done that greatly affect this process. So, for example, much of the fourth year of medical school, so 4 years of medical school in general, much of the fourth year is spent by students trying to get a residency. And this, just the fact that this takes a whole year, chews up an entire year of the curriculum and really makes a lot of the curricular elements less important to the students, or they want them tailored to that residency selection process. And therefore, elective selection in the curriculum is really determined by what they think is going to give them the greatest advantage for a particular residency program, rather than being driven by intellectual curiosity or rounding out your medical knowledge or abilities. And the other thing, there is a pressure by the residency programs to rank medical students and disqualify students from getting residencies because they don't want the low-standing students. So if you rank your students from 1 to 100, nobody wants the 100th person. But that person may have passed a competency-based curriculum, and really, in terms of the minimum competencies, are no different than number 1. But the residency programs don't want that person. And that leads to the final thing, and that is the inappropriate use of tools like USMLE board scores to triage the applicants for determining who even gets an interview for a residency. A recent study showed that only about 15% of all residency program directors would even consider interviewing a student who had failed the boards 1 time. You can take the boards 6 times and pass them. So this is a huge driver of education, and so the students spend inordinate amounts of time trying to polish their board scores or get a good score. They often skip parts of the curriculum because they're off studying for the boards. And really, it doesn't serve the public in any way. All it does is stratify students based on a test of basic science knowledge that's given halfway through the medical curriculum. That's the primary driver of residency program selection. And so I would change that. I would make that test pass, fail, and make the program directors actually review the individual records of the students as opposed to triaging them based on a board score.
Wow, Dr. Jeffries, that is a great insight. I did not know about that. Absolutely amazing take on that. Very cool. Could you possibly give our audience a little bit about where they can find you online and on social media?
Sure. You can find anything you want about our curriculum at med.uvm.edu. We also have our annual report there, and you can see all the new things we're doing with active learning. You can follow me on Twitter at Bill Jeffries, BILLJEFFRIES, and that's pretty much the only social media I'm on.
No, awesome. And for our listeners who are curious, we'll provide the links to University of Vermont's program in the podcast show notes as well. And, thanks so much, Bill, for all that you've gone through. If they're saying what you said at the end, I could definitely say that struck a lot of chords, seeing my fiance going through the program as well. And I thought that was really good to bring out into the light.
Yeah. Well, thanks for having me, and it's been a lot of fun.
No, thank you so much. The pleasure is all ours. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.